So with the results from IMROSE registrational study and benefit academic study that have been presented for the first time at ASCO 2024, there's a new standard of care, which is a quadruplet-based regimen on the basis of a CD13 monoclonal antibody. In IMROSE and benefit, it was Isatuximab, plus the bortezomib Lendex previous old standard of care. This quadruplet has become the new standard of care approximately for any transplant eligible patients, but up to 79, 80 years old, so non-frail patients. We don't have data yet for frail patients, although data is coming. It seems to be saying that the quadruplet will also be applicable to these patients. But for now, it's applicable up to 79 years old, approximately, non-frail. So this is going to be the standard of care. As this logically should be replacing the two previous standard of care, bortezomib Lendex and Lendex. Now, once we've said that, what we have discussed in the symposium that I've been participating to was that now you're going to have the quadruplet-based regimen, a number of triplet-based regimen, doublet-based regimens. So you're going to have a very large palette for options for the patients. And instead of treating all the patients the same way, and once you have treated the patient, to look after the safety and efficacy and decide if you're going to change something, most of the time de-escalate, but sometimes escalate. Instead of doing that, which is what we have done up to now, maybe it's time to rethink the way of giving the treatment to the patients and really deciding at the get-go, at the scratch, at the start, that this patient is fit for the quadruplet and truly I'm going to give it to that patient and manage it. But maybe that patient should receive a triplet, and which of the two triplets, bortezomib Lendex or the Lendex, Lendex, Maya type. And maybe for some patients, only a doublet-based regimen. So what we have discussed is that we would want that now that we have the quadruplet experience with the triplet and the doublet, we could tailor better the treatment, not only based on high risk and frailty, but even more, deeper, further down the road. For example, do you still want to transplant your patient? Or maybe you would want to transplant defer your patient because the quadruplet and maintaining the patient on a quadruplet would be something you could give and offer the patients. So really, we would like to try to change the way the people are doing their treatment, deciding for the treatment at the very early time when they explain to the patients the way they're going to be treated and what will be the plan. And really, at that time point, thinking, well, this patient is fit for a quadruplet, this patient will receive a triplet, etc.